A very good evening to one and all for this online session on chest X-ray interpretation for physiotherapists. So, as you all know, the chest X-ray is one of the inevitable diagnostic tools, investigative tools for the clinical practice. And as we physios, we are involved in the acute care, as we are the part of we are one of the part of the emergency care team. It is necessary for us to have some basic understanding about the chest X-ray interpretation. So, but if you want to discuss the interpretation of chest X-ray of various conditions in and out, we require at least one day, one entire day of an online event, offline event. Actually, we already did in Saveetha, but the feedback was like it was not enough. They requested us 2 days event. So this being said, the very purpose of this session is to give a basic outline, a formula of how to, in what way we have to interpret the chest X-rays. So at the end of the session, we'll be aware of the basic outlines of chest X-ray interpretation with the from the perspective of physios. So there is a systematic approach when we start interpreting the chest X-rays. We shall discuss them one by one. So let us dive into the session now. So initially, we have to confirm these details, the patient details like name, date of birth, etc., and the date and time when the film was taken. And if the previous X-ray is available, you just compare it with the current X-ray to look for any prognosis, any improvement, or whether the condition is improving or it is worsening, like that. And you have to check for the image projection, in which view the image has been taken, whether it is PA view or AP view, means anterior posterior or posterior anterior view or lateral view or digital view, like that we have to check. And these things, means the patient details, date and time, etc., they will be labeled in the film itself. They are known as the image annotations. So we have to look at the image annotations to get these things. Next, we have to assess the image quality, the quality of the X-ray image. So for that, we have to look for these things, whether the image is rotated and whether the X-ray has been taken in proper inspiration with enough amount of breath taken. And we have to look at the projection, whether the X-ray has been taken, as I said before, whether the X-ray has been taken in posterior anterior view, which is commonly used. I'll brief in the next slide for forthcoming slides, or whether it has been taken in anterior posterior view or lateral view or decipitous view, like we have to check for the projection. If there is no label regarding the projection, we have to take, like we have to understand that it is taken in PAV because it is the commonest view which is being preferred. And next thing is, we have to check for the exposure, whether the film is irradiated properly or not, whether it is properly exposed or it is underexposed or overexposed, we have to check. So first, you have to look for the rotation. To check for the rotation, you just look at the film. The medial aspect of the clavicles, as you can see, the medial ends, the clavicle, must be at equidistance from the spinous process. So this thing, this is the spinous process, as you all know. And the medial ends of the clavicle must be at equidistance from the spinous process. This means that the image is not rotated. And then in this image, you can see the spinous process, the medial end of the right clavicle. There you can see the medial end of the left clavicle. They are at equidistant from the spinous process. So this image is also not rotated. So if you want to check whether the image is rotated or not, just check whether the medial ends of clavicles are at equidistant from the spinous process. Another thing is there is something known as the cardiothoracic ratio. Means we have to compare the cardiac width against the thoracic width. So regarding the thoracic width, we measure the thoracic width by drawing a line from the widest part of the thorax in the image. From the inner aspect of the thorax, the widest aspect of the thorax, we will draw a line. And similarly, we'll draw a line from the widest part of the heart. So the width of the heart must be less than or equal to 50% of the thoracic width. If it is more than 50%, then it is known as cardiomegaly. And if the image is rotated, it appears as if the heart is enlarged, but it is not true. So two things we have to confirm. So one is You look for the medial end of the clavicle, it must be at equidistant from the spinous process. And similarly, the width of the heart must be less than 50 percentage or 50 percentage, not more than 50%. So could anyone tell whether this image is rotated or not, or it is normal? You shall
Rotate.
unmute and yes, it is rotated. This image is rotated because you can see that the distance from the middle end of the clavicle, particularly at the right side, is lesser when compared with the left side. It is not equidistant. And the width of the heart is also seen, it also seems to be slightly enlarged. So obviously this image is slightly rotated towards the left. Next, check for the inspiration. So we are checking for the quality of the image. So next, check for the inspiration. So to ensure whether the X-ray has been taken with enough amount of breath has been taken inside, you have to look for the anterior ribs. So you should not misunderstand this like fifth or sixth. It is not fifth or sixth rib. It is five. Numerically, it means when you count the ribs, no, you have to at least five or six ribs must be visible. I'll describe. So in this image, when you count the ribs, one, two, three, four, like this, at least five to six ribs. The number of ribs, five or six ribs must be visible anteriorly. It means that it has been taken in a proper inspiration. And another thing is both the lung apices and the costophrenic angles must be visible. So this is the lung apex. It is visible. They are visible. And this is the costophrenic angle. This is costophrenic angle. It is also visible. And the lateral edges of the ribs are also visible. So to ensure whether the image is taken the proper inspiration, you have to check these things like at least five to six ribs. It is not fifth or sixth rib. It is five to six. When you count the ribs, at least five to six ribs you must be able to count at least five to six ribs, and the lung apices must be visible, and the costophrenic angle must be visible. So this ensures that the image has been taken in proper inspiration. Next, projection. Coming to projection, you have to check whether the film is taken in AP view or PA view. And there are other views also, lateral view and visibility view. But in this presentation, we'll consider about these two views, considering the time constraints. So usually they go for PA view. But if the patient is bedridden or the patient is unable to stand up, they'll go for AP view. If there is no label, there is no annotation regarding the projection, we have to assume that it is PA film. Just I'll brief about the views. So if the X-ray beam is directed posteriorly to the patient, it is known as the PA view. So as you can see in this image, if the X-ray beam from the source is directed it is passed posteriorly to the patient while standing, then it is known as the posterior anterior view. And the image would be like that as if you are viewing it from the front of the patient. And regarding AP view, they pass the beam anterior to the patient. The patient might be lying down in supine or when they might be sitting, and they'll be passing the beam in the front of the patient. And still you get the image which as if you are viewing it from the front of the patient. The difference between PA view and AP view is like that. In the AP view, the scapula, so you can appreciate the scapula within the lung field. So this is lung field. You can see the scapula within the lung field. Then it is AP view. And another thing is like the heart would be it seems to be enlarged. It is not true enlargement, but it is slightly zoomed. So to ensure whether it is AP view, you look for the scapula. The scapula is visible within the lung field. It is AP view. And the heart would be slightly enlarged. And the clavicle would be slightly upward, means at the level of the apex. Whereas here in the PA view, the clavicle is slightly below the apex. So this is the difference. So could you tell which view is this one?
Posterior view, sir.
Okay.
AP,
Could you justify the posterior
AP.
anterior views? This one is AP view. This one is AP view.
Clavicle is straight actually.
Yes.
The clavicle is almost straight.
Yes. And you can also see that the scapula is visible within the lung
Yeah,
field.
lung
Yes.
field.
Yes. So this is AP view, and this one is PA view. Here, the scapula is not visible within the lung field, and the clavicle is below the lung apex. Next, exposure. So, to check whether the film is properly irradiated or not. In this picture, we can see that the hemidiaphragm, particularly the left hemidiaphragm, this is the diaphragm, and this half is the hemidiaphragm. This is hemidiaphragm, left hemidiaphragm, and this right hemidiaphragm. And this left hemidiaphragm must be continuous until the vertebral bone. It must be visible. Number one. And another thing is like the vertebral bodies must be visible beneath the heart. So beneath the heart channel, you are able to see the vertebrae, including the scales are also visible. And so these two things they ensure that the film is properly irradiated. In this illustration, you can see that the hemidiaphragm it is not visible, and you can't see the cardiac borders also. It is very bright. The film is also very bright. We're unable to see the vertebral bodies. So this is improperly exposed, underpenetrated. It is not properly irradiated. This is overly penetrated. This is overly exposed because the film is very blackish, and you can't see the bottom of the diaphragm. It is not. It is blurred. The cardiac cell it is also blurred, and you can see it is very blackish. The film and the lung fields are very blackish, and the bone densities are very brighter. So it is over penetrated. It is overly exposed. So to ensure whether the X-ray is properly irradiated or not, you just look at the diaphragm. The hemidiaphragm must be continuous until the vertebra, and the vertebral bodies must be visible beneath the heart chamber. So this being said, each structures they have their own capability to absorb the radiation. If they absorb radiation in a very good manner, they appear to be dense. If a structure is dense, it appears to be whitest. If a structure doesn't absorb the radiation properly, it appears to be less dense. If it is less denser or if it is lucent, it appears to be black. So you can see this arrow, it indicates the density of various structures, various like air has the lowest density because it doesn't absorb the X-rays, whereas the bone, it has a good absorption capability of X-ray, so it appears very white, it has more density. Whereas these organs or blood or muscle, they appear grayish, they moderately absorb. So you can see in the film. So the lung fields, they are black because they contain air. And the water indicates blood, water or blood, any fluid they absorb moderately. And the bones are highly dense. So following assessing the quality of the film, so there is a particular approach. We call it as ABCDE. In this sequence, we are going to look at the X-ray and we are going to detect whether any abnormalities can be spotted out. So A stands for airway, the in the trachea and the carina and bronchi. And breathing, it includes the lung and associated structures. And cardiac means the heart, the aortic knob, and etc. And you have to look for the diaphragm and everything else like bones, soft tissues, etc. We'll discuss one by one. First, airway. So in this image, you can see. So as I said before, air will be black in color because of its density, low density, less density. So this thing, no, the tubular, the blackish thing, it is the trachea. I think you'll be able to appreciate in the illustration. So beneath the sinus process, you can see a black tubular-like thing. This is trachea. And when you trace the trachea all the way down, so you can see that it is bifurcating. Able to see, if you keenly observe, you can see that the trachea is bifurcating like this. So this is right main bronchus, and this inverted V-shaped thing, this is carina, and this one is left main bronchus. I'll show in the next illustration. Just compare. So this tubular thing, this blackish tubular thing, slightly, you can see the black indicates presence of air inside. So this is airway. So this is trachea, and you can see the trachea is bifurcating into right main bronchus, and this is left main bronchus, and this is carina. Here you can see. So this is trachea, and this is right main bronchus, and this is left main bronchus. This is carina, the inverted V-shaped thing. This is carina. Usually trachea would be in the midline, but it would be slightly oriented towards the right side because of the presence of aortic knuckle. The trachea would be slightly oriented towards the right. But if it is overly shifted, then it indicates some issues. If there is any volume loss like atelectasis or lung collapse, the trachea would be shifted ipsilaterally towards the problem site. Or if there is excessive volume, like for example pneumothorax or volume in the sense there is any means if the trachea is pushed uh, because of excessive fluid outside the lung in the pleural space, then trachea would be shifted contralaterally. So if there is any volume loss, trachea would be shifted ipsilaterally, or it will be pushed out to the opposite side. For example, a pneumothorax or the pleural effusion. So here you can see that the trachea, this is trachea, and this is the right main bronchus, and this is the left main bronchus. Here the patient is having massive pleural effusion in the left side. And so this, because of the presence of fluid in the pleural space, the pleural effusion, you can see that the trachea is slightly pushed towards the right side. So next, breathing. So breathing, when the structures involved in the lungs and its associated structures. First, you look at the hilum. So this is called hilum. This structure, no, this hilum. It is nothing but it contains the vasculatures, the pulmonary artery, the pulmonary veins. The reddish thing is the pulmonary artery. The purple color thing is the pulmonary vein, and this bluish thing is the bronchi airways. So this is what the hilum is comprised of. So usually the hilum, the hilar part it is in inverted C shape. You can see here. This is right hilum and this is the left hilum. And the right hilum is usually larger than the left because the right pulmonary artery is slightly larger. And similarly, the left hilum it is slightly higher than that of the right hilum. You can see here because it is going to wind up over the left main bronchi. And another thing is the hilum. It has the attenuation similar to that of the soft tissue. The density of the hilum, it looks like the soft tissue density. So hilum is nothing but it contains a bunch of the pulmonary artery, the vasculatures, pulmonary artery, pulmonary vein, and also the airways. And it is usually in X-ray you can see that. Uh, so these are the vascular markings. You can see an inverted C shape. And another thing is in the lung fields, usually you won't see airways. So all these things, the tiny branches, branching like things which you observe in the lung fields, are vasculatures. And this is the hilum. So here you can see this is the hilum. This is the right hilum, and you inverted C shape. This is the right hilum, and this is the left hilum. And these things, these branch-like things, are vasculatures. So the right hilum and the left hilum. Left hilum is slightly higher than the right hilum. You can see that there are certain the hilum is enlarged as it be in TB, no, the lymphadenopathy, hilar lymphadenopathy. You can see such things. The hilum, the hilar region will be nodular things will be there in the hilum. So this is abnormal. So you have to check for the hilum whether any lymph nodes are enlarged, or the hilum is thickened, like it might be one of the manifestations of TB. It's coming for the lung. So while radiologically assessing, we classify the lung into three zones: upper zone, middle zone, and lower zone. But kindly don't confuse the zones with the lobes. Lobes are different and the zones are different. Zones are nothing but we stratify the lung field like the one third, each one third of the whole length of the lung is one zone. So this one third, and one third. Like that we divide the lung. The upper zone, middle zone, and lower zone. And we have to observe whether the lung fields are symmetrical in terms of density. If you find any particular part which is overly dense, or if it is loosened, it is very dark or very bright, you have to compare the upper every zones. Like that, you can spot whether there is any problem or not. So this is a normal X-ray. So you can see that the lung fields are clear. These are vasculatures. And the X-ray has been taken with proper inspiration. So there are no issues. So while you are assessing the lung fields, you can see, very well see that it is asymmetrical. You can see a lump-like thing here. So there is a change in the density here. It has a margin-like thing. So probably it might be a lung tumor. Like this, we have to assess each lung field. Next, coming to the pleura. As you all know, the pleura is the outer covering of the lung. But thing is that the pleura is not visible in the chest X-ray. You have to keep in mind that pleura is usually not visible in the chest X-ray. But still, we must assume that the border of the lung field, in the chest X-ray, the border of the lung field, it corresponds to the pleura. Usually, pleura is not visible in the chest X-ray. So you have to start assessing, like starting from what is this point called? Let's see.
Hilum.
Exactly. So this is hilum. So you start from the hilum, and you slowly descend down, and you have to come. What is this thing called? This angulation.
Costophrenic
Yes,
angle.
causophrenic angle. So like this. So start from the hilum, you just come down and you go beyond the causophrenic angle. Like this, you have to assess. You just look whether there is any opaque patch-like thing, or whether it is thickened, or whether it is calcified. Like that, you have to check. So usually pleura is not visible in chest X-ray, but if it is calcified or if it is thickened, or if there is any pneumothorax or pleural effusion, you can maybe pneumothorax, you'll be able to see the pleura. So here you can see the pleural thickening. This is the X-ray of a patient was a coal mine worker. So you can see thickened calcified pleura. This would not this won't be visible in the X-ray, but here it is very clearly evident. This is calcified pleura margins. So this being said, you just look at this X-ray. So you just compare the lung fields, and in a particular zone, no, you can see that there is absence of lung field marking. Could you tell in which part? Just keenly observe this X-ray. As I said before, the lung field, it contains branching like things called vasculatures. And when you keenly observe, you can see that in a particular zone, in a particular part, there are no lung field markings. Could anyone guess?
Diaphragmatic border left.
Um, okay, I'll tell. So
Okay,
you
sir.
can
The
see the,
clavicle,
yes, exactly. Here you can see
clavicle is rotating, medially rotating.
this thing, no, this here. Here you can see that the
Yeah.
rib, yes, there the patient is having a rib fracture. The rib is fractured
Fracture.
here.
Yeah, fracture.
And in this zone, no, you can see that there are no markings. It is very blackish. You can see it is very blackish. These are lung field markings. These branch-like things, no, they are the markings of the vasculature. Whereas in this zone, means the upper zone, left side, the left lung upper zone, you can see that there are no lung field markings. It is very blackish. So and you can also see border-like thing here, a line-like thing. Actually, this is actually pleura, visceral pleura. The patient is having pneumothorax, presence of air into the pleural space. The visceral pleura has been pushed down. So the lung is compressed slightly, and here we don't have lung. The lung is compressed. Here there is only air because of the rib fracture. This is pneumothorax. I'll repeat again. When you keenly observe, you can see you just compare with the right side. So here you can see the lung vascular markings, lung field markings are there. But here you are unable to see any markings. It is very clear and it is blackish. There are no vascular markings here. So the black color indicates air. So there is presence of air inside, but there is no lung. The lung is compressed because of the presence of air inside the pleural space. So this is pneumothorax. I'll show in the next illustration. This one, the same image with annotation. The patient is having fractured rib segment, and this is visceral pleural edge. Visceral pleura has been it is expanded because of presence of air inside the pleural space, and this blackish thing is air escaped in the pleural space. This is pneumothorax. So we have discussed about the airways, the structures associated with the breathing. Next, we shall move to the cardiac region. So when you look at the X-ray, the left border of the heart is made up of the lateral border of the left ventricle. So the left border of the heart is predominantly made up of the left ventricle border, and similarly the right border of the heart, it is made up of the lateral border of the right atrium. So you can see, so is the left ventricle and the right ventricle, right atrium, and we have the aorta here, the pulmonary artery, the superior vena cava. But this takes practice. We have to see a series of X-rays daily, the visual expertise. The main thing is the cardiothoracic ratio, as I said before. So the width of the heart must be. Could anyone tell what is the or what must be the width of the heart when compared to thoracic width?
Less than 50%.
Exactly, it must be either equal or less than 50%. If it is more than 50%, it indicates that there is cardiomegaly. The heart is enlarged. So this is an abnormal X-ray. Here you can see that the heart is enlarged. So the cardiothoracic ratio is increased. The heart is greater than 50% of the cardiothoracic window. Next, diaphragm. So as I said before, so this is the margin of the diaphragm. We call it as the hemi diaphragm, one half of the distance. This is the right diaphragm, and this one is the left hemi diaphragm. And this is the costophrenic angle, the right costophrenic angle, and this is the left costophrenic angle. And this is called as the gastric bubble. This is the gastric bubble. So apart from this, we should observe the aortic knuckle, the bulged part of the aorta, which you can see in the X-ray. It is aortic knuckle. And this is called the aortopulmonary window. The space between aortic knuckle and the left pulmonary artery is called as the aortopulmonary window. So this being said, so we have completed about how to check about the quality of the X-ray and the ABCD approach. Then these areas you have to review. So while looking at the X-ray film, these areas you have to check: head lung apices, retrocardiac region beneath the heart, and behind the diaphragm, whether you are finding any opaque thing or loosened thing. And you should also check for at the peripheral region of the lungs, and you should check at the hilar region as well. So usually these are the common abnormal findings on chest X-ray. Either there would be any lucency, which means that the density is lower than the surrounding tissue. If the density is less, what would be the color of the structure? Could anyone answer? The density is less.
Dark,
Yes,
black.
it is dark. Very good. Darkish or blackish. And if it is opaque, it is called lucency. If the density is less, it is called lucency, and the structure appears to be dark or blackish when compared to the other structures in the zone, lung zone, particular lung zone. And if it is of high density, it is called as opacity, or the structure is opaque. So it appears to be brighter when compared to the other structures in the. So like this, you can this is just the basic outline. So these are the common abnormal findings. Basically, either it would be lucency or it would be opacity, lesser density or high density. So let us start interpreting. With this information, with this limited information, let's try to spot out whether any abnormality is present or not. You just observe at this X-ray, and could anyone tell whether the trachea is normal?
It is shifted towards
It's
the
shifted
left.
towards left.
Yes, it is shifted towards left because you can see that here a sort of mass-like thing is here, probably because of the thyroid tissue. Some problem is with the thyroid, I assume. So the trachea has been shifted towards the left. There you can see this is the sinus process, and the trachea has shifted to the left side. Exactly. There is this is the same X-ray with annotation. The trachea has been shifted, but there is no rotation. It's the actual shift of the trachea because of the soft tissue mass. So what about this X-ray? What do you find here? Look at the hilum.
Lymph nodes enlarged.
Exactly. So there is hilar enlargement, bilateral hilar enlargement. Now in this X-ray, just compare the middle zones. It is opaque or lucent.
Lucent.
You can see that the left middle zone, it is,
Opaque.
yes, it is
Opaque.
opaque. It is opaque, and when you observe such shadow, no, such opaque thing, you just look whether there are some tubular streak-like things, streak-like blackish things. It indicates consolidation. So in consolidation, the silhouette of the organ, the heart is lost. You can see that it is consolidated, and there is opacity, but it is not homogeneous. It is not homogeneous opacity. It is opaque, but it is having some black streak-like things. So these black things are nothing but black streaks are nothing but airways with air inside. Usually airways are not visible in lung fields, but if the lung is consolidated, as if, for example, in pneumonia, where the fluid gets filled, the inflammatory fluid gets filled into within the alveoli, you'd be having such presentation. So this is called consolidation with air bronchogram. These blackish streak-like things, tubular things are known as the bronchogram, air bronchogram, and this opacity it indicates that the lung has been consolidated. So here you can see that there is a mottled appearance. Reticular nodular, we call it as the reticular nodular opacity. It is not normal. The lung fields are not normal. It seems as if like a net, dot nodule-like things. It is usually common in problems with the interstitium of the lung, means the space, the connective tissue space between the alveoli. So if the interstitium is involved, you can see such opacity. So here you can see that there is a homogeneous opacity. There is a homogeneous opacity here in the left lower zone. Could you see any air bronchogram here? Yes or no?
No.
No.
No, very good. So there are no air bronchograms. So definitely it is not consolidation. But you can see that there is a concavity here. It is called meniscus sign. The upper part of it is homogeneous opacity, and this upper part it contains a concavity like this. It is called meniscal sign. So and the costophrenic angle is also blurred. You're unable to see the costophrenic angle here. So these three things: homogeneous opacity, the meniscal sign, and the blurring of the costophrenic angle. It indicates pleural effusion. So in any X-ray, if you see that there is a homogeneous opacity, you look whether air bronchograms are present. There are no air bronchograms, so it is homogeneous opacity, and there is blurring of the costophrenic angle also, and there is a meniscal sign, which means the concavity is present here. So it indicates pleural effusion. And could you tell what has happened to the pleura? Sorry, trachea.
Shifted towards the right.
Exactly. So the trachea is shifted towards the right side because of the pleural effusion. So these three things: meniscal sign, homogeneous opacity, and blurring of the costophrenic angle. And you can't see the silhouette of the heart. So the same X-ray with annotation is the meniscus sign, and this is the effusion. So in this X-ray, could you find any homogeneous opacity in any zone? In which zone you find opacity?
Right upper zone.
Yes, the right upper zone it contains homogeneous opacity, and the patient is also the phosphophrenic angles are also slightly blurred, maybe slightly blurred, but still the significant finding is like there is a homogeneous opacity in the upper zone. Could you see any meniscal sign there? So the answer is no. There is no meniscal
Co-
sign. Here, the upper zone, there is no meniscal sign. So homogeneous opacity, so without any meniscal sign, and you just observe the trachea, and you just tell whether it is shifted towards right or left.
Same side.
Same side.
Right.
So yes, so it is ipsilaterally shifted. So what is your interpretation? What is your assumption? Okay, I'll tell you. So it is volume loss, atelectasis, lung collapse. So if you find any homogeneous opacity like this without meniscal sign, and you can see that the fissure is also displaced, and the trachea is shifted towards the same side ipsilaterally, it indicates volume loss, atelectasis, lung collapse. The upper zone. Here, do you find any abnormality? You just look at the diaphragm, hemidiaphragm, and you can see that there is air beneath the diaphragm. This black thing, no? Air is present in beneath the diaphragm. Maybe because the patient might have intestinal perforation where the peritoneal air has been leaked into the beneath the diaphragm. So this is abnormal. Air should not be present beneath the diaphragm. So maybe patient would have had intestinal perforations. In this X-ray, you can see a sort of opacity with like you can see that the shadowing is almost similar to consolidation. Slightly, you can see bronchogram-like things here, but there are certain lines visible here. The lateral edges, no, you can see these are called as the septal lines. You can see, no, the horizontal linear things. These lines, they are called the curly B or the septal lines. This indicates alveolar edema. So when you keenly observe the film, the X-ray, and you should also correlate with the clinical history also. So when you look at the film, if you find as shadowing like this, as shadowing almost similar to consolidation, but if you're also able to observe some horizontal lines in the lateral ridge, like the septal lines, they are known as the septal lines, it indicates alveolar edema. The, this one is the left side, this one is right side, and this one is the left side. You can see that they are space shadowing and the septal line. So this is the finding of the, this is the presentation of the alveolar edema. And similarly, you can see a bat wing shape opacity here. Also in the next illustration, so you can see that there is a bat wing shaped shadowing. You can see the bat wing. So this is also the presentation of alveolar edema, and this one it may be present in alveolar edema and also in the interstitial edema, both alveolar edema, and if the patient is having interstitial edema also, you can find that mainly the septal lines, uh, they are because of the septal thickness, the alveolar septal thickness. They indicate septal thickness. So the patient is having both interstitial and alveolar edema, you'll be having finding like this. Whereas this bat wing shadowing is purely present in the alveolar edema. You can see consolidation like things in the shape of the bat wing. And in this X-ray, you are able to see the lung field vascular markings, but it is as if you are seeing through a glass. You can see the lung fields, you can also see the ribs also, and you can also appreciate the lung field vascular marking, but still it appears as if you are looking through a frosted glass. So this is called ground glass opacity. It is called ground glass opacity. It is common finding of viral pneumonia. Many people after COVID-19 they had such finding in the X-ray. So this is called ground glass opacity, where you can see the lung fields and the lung vascular markings and the ribs and the bony structures and all, but it looks as if you are looking through a glass. It is called ground glass opacity. So there are certain types of opacities like these three things, linear, reticular, and the reticulonodular. They are known as the interstitial pattern, and this one is alveolar pattern opacity. These are known as the interstitial pattern opacity, and this one is alveolar pattern. So interstitium is nothing but the space between the two alveoli. We have connective tissues there. So you can see that the linear things like this, patchy line-like things. So the interstitium is involved. There is interstitial thickening or fibrosis. Okay, and here you can see mesh-like thing. It is like asterisks, star-like densities, opacities, or mesh net-like opacities. This is called reticular pattern, and this is present in the interstitial lung disease (ILD). It is common finding in the ILD. And here you can see small nodular things. The same reticular pattern, but still you have small nodular, round blackish round things here. This is reticulonodular opacity. It is common among some occupational lung disorders. Similarly, in alveolar opacity, you have fluffy opacities here, fluffy and thick opacities like a scattered here. This is common among alveolar edema. So here you can see that there is a abscess here, a well marginated abscess, a dense and opaque margin, and you have air and fluid inside this white thing, no? This fluid, and the blackish thing is air. So this is lung abscess. So in any X-ray, you find like a margined thing like this with air and fluid level. The blackish thing is air, and this slightly grayish thing appears to be fluid, probably pus. So this is lung abscess. So what is your interpretation of this X-ray? Could you find any abnormality?
Lung abscess in the right upper zone.
Exactly. So lung gap is in the right upper zone. Here, what is the finding?
Pleural effusion.
Pneumothorax, right upper.
Actually, it is a tumor because it has a margin.
Okay.
It has a margin. It is round in shape. It has a
Oh,
margin, but it is solid. Not like it doesn't have air inside. So it is probably a tumor.
okay.
And the patient is also having effusion here because the orthophrenic angle is blunt. So there is also a meniscal sign here. The patient is having effusion. It is the meniscal sign.
Trachea is shifted, no, sir?
Yes, exactly. Trachea is also shifted to the opposite side. And this is called a Hampton's hump, a triangle, a wedge-shaped thing, a wedge-shaped opacity, which is usually associated with the pleural lining. So, as I said before, you won't be able to appreciate the pleura in the X-ray, but still you should assume that the border of the lung field is pleura, and here you can see that there is a wedge, the widened part of the head, wedge is uh, attached with the pleural lining. This is called the Hampton's hump. It is a fight, it's a fighting of the pulmonary embolism. So here you can see the Hampton's hump here. The patient is also having a hilar radican, and there is Hampton's hump. So Hampton's hump is nothing but a wedge-shaped opacity, which is in close proximity with the pleura, and it is usually because of the pulmonary embolism. So this is about the basics of the X-ray interpretation, and just given an outline about the X-ray interpretation of the certain pulmonary conditions also. Next, we shall move to the cardiac X-rays. So this one is a normal X-ray, normal cardiac X-ray, and you can see the lung fields are clear, and we can see the vascular markings. The hilum is clear, and the cardiac width is also lesser than the thoracic width. So this is a normal X-ray. Here you can see a triangular pad-like thing here. Near the left ventricle, you can see a triangular thing. This is actually fat pad. This is not abnormal finding. Usually, people who are overweight, obese people, they might have fat pad. So this is fat pad. This triangular patch-like thing. This is called fat pad. This is not abnormal, but still you have to correlate with the physical findings. This is the heart and this is the fat pad. So here you can see that the cardiac width is more than that of the thoracic width. The cardiac thoracic ratio is increased, so it indicates cardiomegaly. So the cardiac width is greater than that of, means it is greater than 50% of the thoracic width. Moving to left atrial enlargement. Again, you have cardiomegaly here. The heart is enlarged, and there is something known as the double border sign. You can see two borders here, one inner border and the outer border. So this is the left enlarged left atrium. So this, if you find this sign, it is known as it is indicative of left atrial enlargement. So you have cardiomegaly, and there are two borders in the right side. You can see this is the inner border and this is the outer border. I'll show in the next illustration. And there is also splaying of the carina. Carina would be separated apart, to be moved apart. You can see the double right hard border. So is the classic finding of the left atrial enlargement. Next, left ventricular enlargement. The left ventricle, the effects of the heart is usually comprised of the left ventricle, and the left ventricle is enlarged. So the effects of the heart would be displaced laterally and downwards. It is called smooth sign. Smooth is actually a fictional character. So it appears to be, it's a comic character. So the heart appears to be in the shape of the smooth. So the smooth sign is present, then it indicates that the left ventricle is enlarged. You can see the apex is displaced downwards. Right ventricular enlargement. So in the right ventricular enlargement, usually the apex would be shifted upwards. You can see the apex of the heart, which is usually made of the left ventricle, it will be shifted. If the right ventricle is enlarged, the apex of the heart, means the left ventricle will be slightly shifted upward. Here you can see. It's almost like a boot shape. This is a finding of tetralogy of Phaneton. So if it is boot shape, it will be right ventricle has been enlarged. Next, pericardial effusion. In the pericardial effusion, you can see that there is a globular enlargement of the heart. It is round in shape. It is called water bottle sign. It's called water bottle sign. You can see a globular enlargement of the heart. So it is indicative of pericardial effusion. Pericardial effusion, enlarged and globular heart. Next, left ventricular aneurysm. So as you all know, aneurysm is nothing but the segment becomes fragile and it can rupture at any time and it can leak blood. It's a weakened part of the ventricle, the ventricular aneurysm. It is bulged slightly. So here you can see a calcified thing, eggshell. We call it as the eggshell sign, a calcified margin of the left ventricle. So it is indicative of left ventricular aneurysm. In any chest X-ray, if you see the heart in the left ventricle, a calcified ring-like structure like this, it is indicative of left ventricular aneurysm. Aortic dissection, it is actually a life-threatening condition where the aorta gets teared away. And this is it's actually a medical emergency. But if you come across the X-ray of aortic aneurysm, you just look for at the region of the aortic knuckle. I don't know how far I'm able to appreciate here. You can see a thin calcified line in this arrow. Near this arrow, no, you can see a whitish streak like this. And this is the outer border of the aortic knuckle, and this is the calcified border. So the distance between these two borders, the calcified line, you'll be seeing a calcified line in the knuckle of X-ray, and this thing. So the distance between must be less than zero point 0.5 centimeters. If it is greater than zero point 0.5, it is indicative of aortic dissection. If it is more than one, it's a very significant finding. In tetralogy of Fallot, the classic finding is boot-shaped heart. If we find in a pediatric case, in a like neonatal X-ray, a boot-shaped heart, it is highly indicative of tetralogy of Fallot. And obviously, coarctation of aorta, there is narrowing of the aorta distal to the origin of left subclavian artery. You can see the figure of 3 sign. At the level of the aortic knuckle, you can see 3-shaped aorta, figure of 3 sign. It indicates that there is coarctation of aorta. So here we have situs inversus, where the organs are anomalously misplaced since birth. You can see that the heart is at the right side and gastric bubble is at the right side. So the heart would be present towards the right side. Dextrocardia, it is not like situs inversus. In situs inversus, all the organs are misplaced. Means the organs which are supposed to be at the right side are in the left and vice versa. Whereas in dextrocardia, heart alone is misplaced. It is towards right. This is called dextrocardia. And we also have some artifacts like the pacemaker. You can see the sternotomy rings and the valves, artificial valve here. So these are called artifacts. So here you can see that stent, the coronary artery stent is being the spring-like thing, no? The stent. So these are called artifacts. This is defibrillation pad. This is the leads and the defibrillation pad. So far we have discussed about the systematic approach, means in what way we have to observe the chest X-ray and how we can pick up, how we can spot any abnormality in the X-ray, whether it is highly opaque or whether it is highly lucent. Now let us have some question and answer session. Let's have show some few slides. You shall try to interpret. So could anyone interpret?
Left-sided pleural effusion.
Yes. How could you justify?
Cardio.
So it is pleural effusion. Could you justify the answer?
The
We have
costophrenic angles are
The meniscal sign.
homogeneous opacity,
Yes.
More opacity,
meniscal sign,
concavity,
Yes. And you can see what
tracheal
about the
shifting towards
yes, there is also tracheal shifting also. So this,
opposite side.
yes, yes. And what about this? What is this?
right-sided upper zone. Pleural
Yes.
effusion.
For zone?
Lymph node,
lung
hilar,
collapse,
Okay. Is it homogeneous? It is not
No.
homogeneous. No, it is not homogeneous. And you could see some blackish things, no, inside. Black streaks inside.
Radicular nodular. Consolidation of the upper zone.
Yes, it is consolidation. Okay. These red arrow marks, no, just observe the red arrows. These tiny red arrows, and you tell what is
Coaptation
happening.
of aorta.
You just observe the lung field.
Is it collapse of the...
No, you just really observe. Could you see the lung fields here in the left side? Means the lung
No.
field markings. No, no. So there are no lung field markings. It is very clear. And but it is blackish. So black indicates what?
Yeah.
air,
Presence of air. So but there are no lung markings here. But the lung markings
pneumothorax,
are here. Pneumothorax. It is pneumothorax. And you can also see that the tracheal shift also. So it is pneumothorax. There are no lung markings in the lung field. Absence of lung markings. It is blackish. And you can see the pleural border here. The pleural borders here. And lung markings are here. Lung is compressed because of the presence of air. This X-ray,
boot shoe appearance,
boat shaped heart. Sorry.
Tetralogy of Fallot.
What about this?
Bottle shaped appearance.
Uh,
Right
could you see two borders
ventricular.
here?
Right
Yeah, right
atrial
right ventricle,
atrial
hypertrophy.
Yes. Right here
enlargement.
enlargement. What about this? You look at the orientation of the heart and you
Vitus
observe the gastric bubble.
invertus. Vitus
right side,
invertus.
dextrocardia,
Yes.
Invertus side.
Situs inversus.
sinus,
Very
situs,
good. Yes. This one,
pericardial effusion,
very, very effusion. It's globular enlargement of the heart. This one?
Multiple abscess.
Lung abscess.
Yes, lung abscess, multiple lung abscess. You can see
Multiple.
multiple. Yes, exactly. This one?
Hilar enlargement.
Lung tumor, sir.
Hilar, near the hilar ridge.
Okay, hilar region is abnormal. Enlargement of the hilum. You can see how the hilum is enlarged. Yes.
It aortal dissected.
Left upper zone is, right upper zone is
Oh.
no.
Fusion.
You also observe the trachea.
Towards the same side. Atelectasis.
Very good. It is atelectasis. The homogeneous opacity without any bronchodram towards yes. So this lung collapse, atelectasis. So thank you all for your kind cooperation and for the wonderful interaction. I thank the organizers for this wonderful opportunity, and thank you also plan for an offline session because of the time constraints. We actually need at least 1 day session, entire session, or one or even 2 days would be enough for the just X-ray interpretation in and out. But I hope that the purpose of this session is accomplished. Means my objective was to give an outline or to just convey the formula in which in which direction we look for the abnormalities in the chest X-ray. I think could be accomplished. So thank you all. Thank you so much, sir.
Thank you,
Thank you,
sir.
sir. It's beautiful for us, sir.
Thank you.
Thank you, sir.
Thank you.
All right. Participants, any questions you can share on the chat box or you can ask directly to Dr. Aravind. Any questions which you like to ask?
Sir, can you please explain ground glass opacity again? It was
Yeah.
not clear.
Oh,
And also about the honeycombing, if that also, can you please explain?
yeah. Actually, honeycombing, I don't have the film right now, no, but if we plan next session, I shall share the. But currently, I don't have the film. I can explain, but you won't be able to get it. I don't have the illustration right now. But as of now, I'll just tell you about the ground glass opacity again. So in ground glass opacity, actually, when you observe the lung fields, you'll be able to appreciate the lung field markings. The vasculature will be appreciated, and you can also see the ribs also, the bony structure, the heart, the silhouettes of the organs. You can appreciate them to some extent, but still, it would be as if like you are viewing it through a glass, a frosted glass, as if you are viewing it through a glass. So it is called ground glass opacity. The lung fields would be visible. The lung field markings are also visible, and the bony structures are also visible. The silhouettes are also appreciated to some extent, but still there is a sort of frozen sort of opacity. It is called ground glass opacity. It is a finding in viral pneumonia. And
Okay.
apart from these, we have several these things findings also. But I have shared only a handful of conditions alone, considering the time constraint. So probably in forthcoming offline or online sessions, we can discuss in and out other conditions also. As you said, the honeycomb appearance. There are many other things which we discuss. So this is just an outline.
Okay, sir. Thank you.